Great, thanks, Melina, and thanks everyone for being here. Um, I certainly welcome any questions that you may have. What I'm going to do is I'm going to talk to you about some work that I have done with a former PhD student on predictive analytics related to transfers to the ICU. And this problem setting that we looked at was actually in Northern California at the Kaiser Permanente healthcare system. And I'm sure that all of you have been hearing more about ICUs over the past 8 months, as this is a critical resource in terms of addressing the COVID-19 pandemic. So to tell you a little bit more about intensive care units, at hospitals, these units are typically the highest level of care. And what that means is that there's typically one nurse that is treating one or at most two patients. And so, in fact, in California, there are laws that that prohibit nurses in the ICU from treating more than two patients. Because of this high staffing cost, and also because of the specialized equipment that are required in the ICU, such as ventilators, they're incredibly expensive to operate. They consume a disproportionate amount of hospital operating costs, despite being a small number of the beds. And so it's actually, only about 10% of patients ever end up in the ICU, but they are very critical patients. And so it can be problematic when access to ICU care is limited. And we saw that, in fact, early on in the pandemic. I'm sure that you've read stories coming out of Italy where there were concerns and ICU physicians were actually having to make triage decisions about who was able to get this very valuable resource. But even in non-pandemic times, these units are incredibly important in terms of treating the sickest patients within the hospital. So there's been a lot of work in the medical literature that actually demonstrates timely access to care for the ICU is associated with better outcomes. And certainly this is intuitive. If someone is very unstable, very sick, getting care earlier is actually associated with better outcomes. In fact, some of these studies that I've listed have demonstrated that delays in getting into the ICU are associated with increased risk of death and longer length of stay in the hospital. Recognizing this, many hospitals have employed what are called rapid response teams. And so this is a team of clinicians that will go to the bedside of a patient who is not currently in the ICU and essentially bring critical care to them to assess whether or not that patient needs to go into the ICU. The idea being that if we can identify these unstable, at-risk patients early, you can move them into the ICU earlier on and make sure that these delays can be avoided. So what many hospitals utilize are early warning systems. And so there's a couple of different early warning systems that exist out there. The idea being that these are scores that determine the risk of a patient deteriorating. And so the most popular ones that are used are the modified early warning score and the national early warning score. The national early warning score actually comes from the UK. Now, the nice thing about these scores are that they're very easy to calculate. So this is a table here that demonstrates for the national early warning score how to calculate it. Essentially, there are 5 different vital signs that are measured. Depending on the range of those vital signs, a patient will get different scores. So the normal range is right here in the 0. And if you deviate, either having a heart rate that's too high or a heart rate that's too low, you start adding scores. And at some point, if your score hits above 4, then an alert will occur. So as I said, the benefit of this score is it's very easy to calculate, but there are drawbacks to it. So unfortunately, it's associated with having high false positive rates, meaning that people, the physicians are alerted to a patient who ends up being fairly stable and not needing to go to the ICU. This is problematic because alert fatigue is actually a very real problem in hospitals. And so you don't want constant alerts. Otherwise, clinicians will ignore them, and that renders the scores useless. On the other side, there are also high false negative rates. And so this means that there are patients who are going to deteriorate, need interventions, and they're being missed. So why do we care about this so much, and trying to understand how to utilize these scores is that these unplanned transfers, so patients who are outside of the ICU, whose physiologic state is deteriorating undetected, and eventually get transferred into the ICU, they tend to be much worse off. So in our study setting in Northern California, Kaiser Permanente, we find that patients who are directly admitted to the ICU have higher predicted risk of death than those who deteriorate and are experience an unplanned transfer. But the observed mortality rate, the relationship flips. So those direct admits have a mortality rate that's actually half those of the unplanned transfers. And they actually stay a shorter amount of time. So this is very problematic. So what this project entailed was actually utilizing machine learning tools to build a more sophisticated early warning system that addressed some of the deficiencies of those scores that I just showed you, and then deliver proactive care based on that score. And what I mean by proactive care is actually potentially admitting a patient to the ICU before things get really bad, based on the score, based on the fact that they are at high risk of deteriorating, but you haven't actually seen the deterioration occur. So the score that was developed is called the Advanced Alert Monitor. It was based using data from 21 hospitals of over nearly 650,000 hospitalizations. This data contains various information about the patient, their age, the gender, what is the primary condition for which the patient was admitted, and then it tracks vital signs. And it's not just the actual point value of the vital sign at a period in time, but also trends. So it's very different if a patient has a normal low heart rate, that might be fine. But what's concerning is that their heart rate is changing erratically, very rapidly. And so looking at trends rather than the single moment in time, as in the case with the NEWS and MUSE early warning score is a much potential improved scoring system. So what this score does is that actually it predicts the probability of patient deterioration. I won't go into the details of the machine learning algorithm and covariates, but it uses a logistic regression. And essentially every hour, the score is providing a risk probability of the patient deteriorating and needing to go to the ICU or dying in the next 12 hours. And it's based on information from the past 12 hours. Then every hour, this score is going to be updated based on whether or not new vital signs have been measured, if lab tests have come in, and how changes may have been. So the question then is, if we have such a predictive score, how should care actually be implemented based on this score? So that's what we want to focus our attention on. For those of you, I'm just flashing it quickly, for those of you who know and recall from your business analytics class, perhaps, ROC curves, the new advanced adult monitoring system does have better predictive power than other state-of-the-art early warning systems that are there that are being used. Okay, so what is our goal? Our goal is to understand the impact of proactive admissions to the ICU. So on the one hand, clinical intuition and some other studies in the literature demonstrate that early access to care can improve outcomes, so reduce hospital mortality risk and have potentially a shorter length of stay. On the other hand, if we are making admission decisions based on a risk score, so a probability someone is going to deteriorate, that means that there are some patients who are not going to deteriorate. There's some risk that they don't actually get worse. And so you may be admitting this patient who would never need ICU care ever. And so there's a cost associated with it. You could be utilizing this very expensive resource unnecessarily and potentially blocking other sicker patients from getting access. And so this is what we want to really try to understand, this tension between these potential benefits and the potential costs. So the approach that we end up taking is twofold. First, we empirically estimate from data what is the value of these proactive transfers on patient outcomes. And then based on these estimates, we use simulation to understand how different proactive transfer strategies may impact the system dynamics. All right, so what is the effect of proactive admissions? So what we want to do is estimate what's referred to as the causal effect of ICU admissions. So we want to see if someone is admitted, does the admission actually cause better or worse outcomes? And the challenge in doing this with retrospective data is that patients who are admitted to the ICU are likely to be sicker than those who are not. So if you just naively looked at a comparison of those who are admitted to the ICU versus those who are not admitted to the ICU, it would look like going to the ICU results in worse outcomes. It kills patients and it makes them stay in the hospital longer. Now, the issue here is that we're looking at retrospective data. The state of the art in terms of science to really extract the causal effect would be to run a randomized trial where you did a coin flip and you admit a patient to an ICU if they get a heads and they don't get admitted if they get a tails. Now, clearly doing such an experiment is unethical, as we know that ICU care results in better outcomes. And so we take an approach utilizing tools from the causal inference and statistics literature related to instrumental variables and matching that allows us to essentially mimic a randomized study. So essentially the idea here is that there are other extraneous external factors that result in variation of who gets admitted to the ICU, and we leverage that variation in the data. And so what we end up finding is that indeed, proactively admitting a patient to the ICU results in better outcomes. So we see a 2.5% reduction in mortality risk and an over a day reduction in hospital length of stay by doing this. So this seems wonderful for these patients. Getting ICU care earlier is certainly beneficial. So we have better individual outcomes, but we really want to understand what's the system level effect, right? We kind of intuitively expected that for individuals it'd be better, but what about this tension of admitting patients early may block other patients? So what we do is we created a simulation model to really understand if the ICU care is expensive and beds are limited, which patients should be proactively admitted, how is this going to impact the overall congestion and access to care, and the system level patient outcomes. Because while it may improve the outcome for one patient, if it blocks a whole bunch of other patients from coming in, it could degrade their outcomes. All right. So we created a simulation model that has patients who are in the general medical surgical ward. They can go to the ICU either through a proactive transfer or they crashed and have to be immediately transferred. So they deteriorated. And we essentially simulated a whole bunch of different transfer policies. So what did we find? On the x-axis, I have the average ICU occupancy. On the y-axis, I have the overall in-hospital mortality rate. And each curve corresponds to differences in the total number of patients arriving to the hospital per day. So up here is a more congested hospital that has more patients arriving, and this is the a less heavily loaded hospital. Each point corresponds to a different proactive transfer policy. Oops, excuse me. So the reactive dot corresponds to the status quo. You only transfer a patient to the ICU once they've deteriorated and it's clear that they need care. I could then consider transferring just the top severity score or the top 2 severity scores, top 3, and keep increasing. And what I want to draw your attention to is certainly as you become more aggressive in proactively transferring patients, your ICU occupancy is going to increase. This is going to create access issues for other patients. But what we can see is kind of this sweet spot up here where you can substantially reduce the in-hospital mortality risk with very minimal impact on the ICU occupancy. This is because, remember, for those very sick patients, being admitted early is associated with reductions in their length of stay. And so we actually, even though we're adding more people in, they're not staying as long. And so it's almost a win-win situation that there's an opportunity to utilize proactive transfers to improve outcomes, but you can't be too aggressive in doing that. So what ended up happening, they ended up actually implementing the threshold-based rule to alert patients to the bedside. They ended up actually, because of the challenges with alert fatigue, instead of having the threshold as we recommended, they put it so that it would be at most 1 alert per day, because they didn't want to overly burden the clinicians. And so they ended up, after piloting at 2 hospitals the score, they conducted analysis to demonstrate that actually having this rule and having the early warning system available based on machine learning reduced the ICU length of stay by up to almost 7 hours, and reduced by almost a third the 30-day mortality rates, which is quite substantial for these patients. And so now this early warning score is available and is being used at all 21 of their hospitals real time now. So I guess I want to wrap up a little bit. I think machine learning is certainly growing in the healthcare space. There's a lot of opportunities. And so what this work really focused on is how do we make decisions based on these predictive analytics? So to go from prediction to prescription. And there's a fine balance here. So being proactive can certainly result in better outcomes, but being too aggressive can be quite detrimental. I just want to turn back to the world that we're living in. COVID-19 has made ICU care much more strained. And there are now many hospitals who are kind of at their capacity limit. And this work and other work that I've done has demonstrated that early access to care is much better, but the resource limitations are jeopardizing our ability to give this early care. And so for those who are interested, I'm happy to talk offline or send you information. I did another study with some clinicians that appeared in the Annals of the American Thoracic Society this summer, related to how alternative therapies can be utilized for COVID-19 patients when ventilator capacity may be scarce. So with that, thank you for the attention, and I'm happy to take any questions.
Thank you so much, Carri. We have a couple questions. The first is from Timothy Koo. Why not run a prospective trial that randomizes patients to the new protocol versus standard of care, as opposed to the scenario that Professor Chan mentioned on a coin flip on ICU admission?
That's a great point, and that's essentially what it wasn't randomizing patients to the new protocol. What the study that was more recently done that implemented the early warning system and then compared the 2 hospitals that had the new early warning system compared to the other 19 hospitals that didn't, allowed for that study to get the causal effect of the difference between using the machine learning algorithm and not. The challenge was, before this happened, there was actually quite a bit of skepticism from the physicians to use the score in the first place to make decisions on care. And so we didn't yet have buy-in to implement a new protocol. And so we needed to use retrospective data to say, hey, if you did utilize this, this is the potential savings you could have.
Okay, the next question is from Yu Hu, and she compliments you. Thank you so much. She enjoyed Carri's presentation and would like to ask if rapid response teams are still in use after the prediction model was piloted.
Yes, so they are still using rapid response teams. And so what they're doing is that when the alert goes off, so basically on all of the nursing stations, all of the patient's vital signs and labs are being updated to provide this score real time on the monitor. And so if any patient risk score crosses the threshold, a pop-up will go on the nurse's monitor, and texts will go to the physicians, and the rapid response team will go to the bedside of the patient. And so then they'll make the determination, was this a true alert? So should we start admitting patients, this particular patient, to the ICU? Or is this patient maybe like normally is kind of their risk score, maybe it just happens to be higher, and they'll just monitor them. So the rapid response team ultimately then makes the decision whether or not to admit the patient to the ICU.
Okay, thank you. Third question is from Michael McCormick. Would you recommend that hospital systems have a lot more slack in their staffing to allow for the ability to meet the demand of COVID, this COVID wave beginning anew?
So I think it's a really challenging question. Staffing is certainly one of the most financially intensive costs in a hospital. And so it is not desirable to be paying for a lot of staff that don't have anything to do, right? So you need to have some flexibility for when extraneous circumstances such as a COVID-19 outbreak occur, but COVID-19 is a rare event, and so it would not be reasonable to always staff your ICU to meet the peak COVID-19 demand. In New York City, within like 2 or 3 weeks, they doubled ICU capacity. How was that done? They shut down all the operating rooms and turned operating rooms into ICUs. They brought in staff from other states. They had everybody working overtime, but that's not sustainable long term. And also right now, it's a very real problem that our staff, our clinicians, our frontline employees are burnt out. Taking care of COVID-19 patients is incredibly draining. And so even if hospital systems wanted to add more staff for Slack right now, it's not clear that that even would be possible. There are places that are struggling to hire the clinicians that they need because many people who are working on the front lines have decided to transition their role just given the amount of burnout. And so that's something we just need to be wary of as well.